I'm just checking if all the speakers got their video on and have unmuted their mics. Okay. Good afternoon, everyone. Welcome to this Bhekisisa webinar that we're hosting in partnership with the Aurum Institute. I am Mia Malan, the Bhekisisa Center for Health Journalism's editor-in-chief. For those of you who are not familiar with us, Bhekisisa is a media startup based in Johannesburg. We produce health features and analysis, and we also host media trainings. The Aurum Institute is a leading health impact organization focusing on TB and HIV research. Today, our webinar will focus on the relationship between COVID-19, TB, and HIV. And if you wanted to follow Bhekisisa's live tweeting on this webinar, you can follow us on @Bhekisisa_MG. And if you wanted to live tweet yourself, you can use the hashtag Bhekisisa webinar. We've got a really excellent panel of world-renowned scientists and an influential TB activist lined up for today. To quickly introduce you to them, we have Mary Ann Davies, who is a public health medicine specialist in the Western Cape government, where she's responsible for epidemiology and surveillance. And we're very excited that she will release South Africa's first public data on COVID-19's death risk posed by TB and HIV today. Then we have Gavin Churchyard, who is the founder and CEO of the Aurum Institute. And Gavin is also an honorary professor at Wits University and the London School of Hygiene and Tropical Medicine. We also have Francois Venter, who is the Divisional Director of Ezintsha, which is a subdivision of the Faculty of Health Sciences at Wits University. Francois is also a member of South Africa's Ministerial Advisory Committee on COVID-19. Lastly, we have Phumeza Tisile, who is a health activist and a student at the University of Cape Town. And in 2010, she was misdiagnosed with normal TB when she had multi-drug resistant TB. She co-authored and presented the first drug-resistant TB manifesto at the World Health Assembly in 2014 in Geneva. So these are our panelists, and here is how our webinar will work today. It will be 1 hour and 15 minutes long, and roughly half of the time we will spend on presentations and remarks, and the other half on getting our panelists to answer your questions, the participants. So we're going to start off with a 10-minute presentation by Mary Ann Davies on the latest data relating to HIV and TB with regards to the death risk for COVID-19 patients. And I will then ask Gavin, Francois, and Phumeza each a question to which they will respond with an answer of about 5 minutes. And after that, we will move on to participants' questions. Many of you already submitted questions when you registered for the webinar, but I will also incorporate some of the questions you enter into the chat room on Zoom and also on the chat section of YouTube during this webinar. So Mary Ann, we're ready for you. You have a PowerPoint presentation. If you could share your screen with us and start, that'll be great.
Thanks. Can I just confirm that you can see my screen?
I can absolutely see it, yes.
Okay, thank you very much for this opportunity to share preliminary data from the Western Cape on the interaction between COVID and HIV and tuberculosis. And I want to start out by acknowledging our healthcare workers across the province who are at the front line of our COVID response, but also without whom we wouldn't be able to share this key information. So when we started to see the first cases of COVID in South Africa, we wanted to know in our population with our particular demographic and comorbidity profile, who would be at highest risk of poor outcomes. And there were several risk factors that we already knew about from other settings. For example, we already knew that older people were more likely to die from COVID and that people with certain comorbidities like diabetes were more likely to have severe COVID outcomes. But two key high burden comorbidities in our setting are, of course, tuberculosis and HIV. And there really hasn't been much data about whether these comorbidities increase your risk of poor outcomes with COVID. To try to work out the effect of different risk factors for death can be quite difficult because some of those risk factors are linked to each other. So, for example, people who are diabetic may also be more likely to be overweight, and we know that both diabetes and being overweight increase your risk of COVID death. So what we need to do is to try to disentangle the effects of each of these individual risk factors to work out how big a role each risk factor is playing. And in epidemiology, we talk about that as dealing with confounding. And in order to do that, we need good data at a population level on all of these factors and, of course, on COVID outcomes. And getting that good data is not easy, but we are very fortunate in the Western Cape in that across all of our public sector health services, we are able to put together data from several different systems on individual patients using a unique identifier, which is used across all of our data systems in the province. And we bring that together in something that we call the Provincial Health Data Centre. So the Provincial Health Data Centre, or PHDC, brings together data from our emergency centres, our hospitals, our primary care clinics, our chronic disease management systems for HIV and tuberculosis, our laboratories, and importantly here, this includes SARS coronavirus 2 tests, and we were able to bring in both tests done in the public and the private sector, and then from our pharmacies, as well as a range of other systems. And this gives us data which helps us to manage patients optimally, but also importantly, helps us to understand the comorbidity profile of our different patients. And the way that we can do that is to use the information we have on laboratory tests and medications that have been given to infer that patients have different conditions. So for example, if someone's had a laboratory diagnostic test for diabetes, or if they are receiving anti-diabetic medication, we can infer that they are diabetic. Similarly, if someone's had a laboratory diagnostic test for HIV, or if they've had a viral load or a CD4 test done, or if they're receiving antiretroviral therapy, we can infer that they have HIV. And there are a range of conditions that are actually quite easy to infer on that basis. There are some conditions that are harder to infer, and those are things that we don't diagnose in the laboratory or we don't treat with a medication. So things like being overweight or obese, habits like smoking, and things like socioeconomic status. And so we're not perfect, and some of those effects are a little bit harder for us to disentangle and look at the risk factors. But for those comorbidities that we do know about, we were able to take all 3.5 million patients who are active in our public health system, in other words, who've had a visit to a health facility in the last 3 years, and look at the factors that are associated with COVID death in association with each of those comorbidities in our population. And these are the key results. And what we really want to know is, well, what are your chances of dying from COVID if you have different risk factors? And the way that we look at this in epidemiology is to say, how much more likely are you to die if you have a particular risk factor, let's say if you're older, compared to if you don't have that risk factor, if you happen to be one of those lucky people who's under 40 years of age. And you can see that that risk increases, and that people, for example, who are over 70 are nearly 20 times more likely to die from COVID compared to the fortunate under 40s. We're not so interested in the absolute risks that we see there, but what we're rather interested in as epidemiologists is the range of values for those risks that are compatible with our data, which is something that we call the confidence interval on the right-hand side. So for example, for those over 70, we can be reasonably certain that the increased risk that we're seeing in our data is somewhere between 12 and 30 times as much. And it can be easier to look at this graphically. So in the figure on the right-hand side, it's essentially the same results as you're seeing on the left, but just in the form of a picture. The red line is where there is no increased risk or increased chance of dying. And then the blue dots to the right, for example, if we look at age, show the number of times that you are more likely to die if you have that particular risk factor. And you can see that clearly as we move to older ages, that number of times is higher. And the black whiskers around the blue dots are the confidence interval or the range of values that are compatible with our data, which I talked about previously. And importantly, if those black lines don't cross our line of no effect, the red line, then we can be reasonably sure that we are seeing an increased risk for a particular risk factor. So in our data, we clearly see that men and people who are older are more likely to die from COVID. And this is exactly what we expected, because we have seen this from international studies, and our data mirrors that pretty much exactly. Similarly, when we look at non-communicable diseases, we see that diabetics have a substantially increased risk of COVID death, and that this risk increases for those who have poor diabetic control. And we also see an increased risk for people with high blood pressure and chronic kidney disease. If we now move to the comorbidities that we haven't learnt about from other settings, tuberculosis and HIV, we can see that for people with previous tuberculosis, there's a small increased risk of death. People with current tuberculosis, that's a little bit higher, about 2.5 times. But these are much smaller than the risks associated, for example, with diabetes. And then for people with HIV, we're seeing about a 2.75 times increased risk, with a range of values between about 2 and 3. And again, although that is an increased risk, it's much smaller than the effect that we're seeing for several of the other comorbidities. What's curious is that when we compare people who are virally suppressed and those who are not virally suppressed, we see this increased risk for both of those groups of patients. And this is not what we expected, because we thought that if there was any increased risk of death associated with HIV, that it would be driven by people not being on treatment and having poor immune function. But it seems that whatever's going on is a little bit more complicated than that. And there's clearly a whole lot of more research that needs to be done to really understand this more fully. So what does all of this mean at the level of the population? Well, if we had to look at how much each of these comorbidities is contributing to deaths that we're seeing, and if we had to say, for example, looking at 100 people who have died from COVID in the public sector in the Western Cape, what we can see is the overwhelming majority of those deaths are due to diabetes. We also see a large contribution from high blood pressure, and then smaller numbers from kidney disease. About 12 of those deaths can be attributed to HIV, and about half that number to either current or previous TB. So these are very important findings for us to understand what's driving the risk of COVID death in our setting. But whenever we have results like this, we always try to confirm them by taking a different approach and seeing if we get the same answer. And also these results are limited to our public sector patients. So what we also did was to calculate something called the standardized mortality ratio. And what we're looking at here is the actual number of deaths in people with COVID and HIV. And we're comparing that to how many deaths we would have expected if people with HIV and COVID had the same risk of death as people without HIV. And the headline finding is that that standardized mortality ratio is about 2.3. So that's very similar to the 2.75 we found in our public sector patients, a little bit lower probably because we're adding in private sector patients here as well. And if we have to say how much mortality across both public and private sector is due to HIV, we estimate that to be about 8%. So our take-home messages, clearly we are seeing the same effects that we've seen from international studies, and older age and comorbidities place people at substantially increased risk of COVID death. We've known about a lot of these, but what's new from our data is that we've been able to quantify the effect of HIV and TB, which until now we haven't known. And we might have expected that effect to really be very large, but in fact what we're seeing is a fairly modest, around a 2.5 times increased risk of COVID death with these conditions. Importantly, that risk might be overestimated if we haven't fully disentangled all of the comorbidities and risks that drive COVID death, and particularly here I want to emphasize overweight and socioeconomic status as potential factors that need to be thought about. And the other important factor to consider is that people with HIV and TB tend to be younger, and younger people tend to have an overall risk of COVID death that is low. And so the absolute increase in deaths due to COVID, or the absolute number of deaths, due to HIV, the absolute number of COVID deaths that HIV is responsible for is relatively low, and at a population level is less than 10%. And I'll just end by saying a huge thank you to people across the province who have been working incredibly hard, both on caring for our patients, but also to be able to share this information, and to thank our patients themselves. Thank you.
Thank you very much for this, Mary Ann, for this really important and meaningful data. Could you please unshare your screen?
Sure.
Thank you very much. So let's move on to Francois. Francois, we've now heard a bit more about how TB, HIV, and COVID-19 interact, but we also know that the large amount of resources spent on COVID-19 has impacted negatively on HIV and TB services. What is the current situation?
So just firstly to acknowledge that I don't think maybe everyone understands how revolutionary Mary Ann's data is. Like, it's the first proper African data we have to start comparing ourselves against the rest of the world. And there are other cohorts coming through, but I really, I think everyone should just mull over what she's just told us, which is with huge implications for how we run our health programs, how we respond to COVID. So regarding HIV, HIV is one of those public health successes the Department of Health can claim, and a sea of a lot of challenges over the last 10 years. We've seen a dramatic expansion of the HIV treatment program, and with it, we've seen death levels come right down. There's been associated impact on the TB program, which is for the first time in decades shown real benefit. Gavin's going to talk about, but real moves forward. But most importantly, we've seen almost a halving of the HIV incidence data. So new infection rates have plummeted in the last 5 years. So on the back of this, we've got, it's not perfect, but it really is a feather in the cap of the Department of Health in terms of a relatively successful HIV program that's starting to pay dividends left, right, and center, and where the cause of death, as we're on the death certificates of HIV, has plummeted from number 1 down to about number 6. Leaving TB and diabetes at number 1. So in the sea of success, now we get this virus, a different virus coming along. And what we've seen is very dispiriting. We've seen firstly the number of viral loads being done starting to drop. And we're in the midst of a transition to this new wonder drug, dolutegravir, which unfortunately is not quite as wonderful as we wanted, but is pretty good. But we should be seeing a lot more viral loads being done. Instead, we're seeing about 10% drop in the number of viral loads being done by the National Health Laboratory Services. We're also seeing a decrease in the CD4 count, a number of CD4 counts being done. Gavin can talk about TB as well, but also TB testing rates have come right down, which demonstrates that people are just not attending the clinic. So that's the hard data to suggest health-seeking behavior for HIV and also for TB is not has been impacted by the epidemic since the lockdown started. I think what I'm experiencing is huge amounts of case reports coming from my colleagues on the front lines, as well as from patients I've looked after over the years, talking about how they're afraid. And there are different fears that seem to interface in this, but it's quite clear that we are seeing people not picking up their prescriptions. And that is an absolute catastrophe. For 2 or 3 weeks, it's not a catastrophe. For the length of the lockdown that we've endured at the moment, it is a catastrophe for the HIV program, because once you fall off therapy, your CD4 count starts dropping, you start being exposed to all those bad things that we've all been taught about. And it seems that the reasons for people not accessing care are quite complex. People are scared of getting coronavirus within the health facilities. They're scared that the facilities aren't prepared. They're also, something that's been recurring is they're scared of the police. They're scared of being arrested on the way to that. That seems to have settled in the last week since we went to lockdown level 3. But certainly under 4 and 5, people seem to be quite scared of the cops. and of the army. And the third thing that's been voiced quite a few times by patients through the advocacy groups, as well as people just contacting me, is that they are afraid that they'll be tested, and if they're tested positive, they'll be incarcerated. There have been a couple of unfortunate political statements by MBCs talking about, incarcerating people if they don't self-isolate themselves. And because you're going to tell, there was initially a statement that said all people who tested positive would be forcibly incarcerated, quarantined. So I think there hasn't been very good public health communication from the Department of Health around this, unfortunately, and what this has led to is, I think, just generalized fear and less health-seeking behavior. The problem with this is we're going to see, probably more so in the TB program than the HIV program, because most of the HIV programs we can still get on top of them quite quickly if this is relaxed, is going to see a wave of sickness and death in the next 6 months, which are going to be as much of a problem as coronavirus is going to be for the health system. So I think we need to anticipate huge challenges in the next 6 to 9 months that are going to be mopping this up. And that's just TB and HIV. I think things like vaccines, the non-communicable disease like hypertension, diabetes, all of those are probably as much impacted as the HIV program.
Thank you very much, Francois, and thank you for also pointing out the importance of Mary-Ann's data. I would like to move on to Gavin. Gavin, in the light of the vulnerability of TB patients to COVID-19 disease, would it be fair to say that now more than ever is the time for preventive TB treatments such as 3-HB?
Thanks so much, Nia. Yes, this is true. And again, just to congratulate Mary-Ann on all that amazing data that will help shape policy. So we have seen, so just give me a moment, my screen's not advancing.
Sure.
Right, so did you see the slide advance?
Yes, it is. It's all.
So I will be examining this interaction between TB and COVID-19 and with HIV, and it's more of the same as Francois has already described. But there are potentially biological interactions between TB and COVID-19. TB infection and disease may increase susceptibility to COVID-19. Very limited data from China, but there is some data to support this. And as we've just heard, may potentially worsen COVID-19 outcomes, although maybe not to the same extent as other comorbidities. COVID-19, however, may increase the risk of progressing to TB disease in TB-infected persons. We don't yet have the evidence to support this, but it's to be expected given we see this with other viral infections, etc., and diseases which can precipitate progression to TB disease. COVID-19 may worsen both TB treatment outcomes as well as exacerbate post-TB lung disease, given that both attack the lungs. However, the impact of the COVID-19 response on TB has been to reduce the number of diagnostic tests for TB by about half. It's also substantially reduced the number of patients treated for TB, the number of contact investigations done, and we've heard in some countries this disclosure that preventive therapy for people living with HIV and household contacts has been deemed to be a non-essential service and therefore stopped altogether. In countries where it hasn't been stopped altogether, we've seen substantial declines in the number of people starting preventive therapy. This is important in terms of in the context of the UN high-level meeting on TB, which set very ambitious targets for finding TB cases, treating TB cases, and preventing TB. Mathematical modeling done by the Stop TB Partnership examined the impact of COVID-19 response on TB control in high-burden countries. And as an example of a country with both a high burden of HIV and TB, they used Kenya. And what this showed was that the lockdown for a limited period of, say, 2 months with a fairly short recovery period had a modest impact on the TB epidemic. However, if the lockdown was extended to 3 months, and there was a prolonged recovery, then the impact was substantial and prolonged. And over a period of between 20 and 2025, the 3-month lockdown with a protracted 10-month restoration period could lead to additional 6.3 million cases of TB and 1.4 million TB deaths. A modeling exercise was done for South Africa, also looking at the intensity of the lockdown, what they call the mitigation, suppression, etc. These are just basically the intensity of the lockdown and the duration of the lockdown. And as we saw for Kenya, the same is true in South Africa, that the more prolonged the lockdown is and the more intensive it has been, the greater the impact will be on TB-related deaths. There is some good news, however, turning back to the modeling that was done for Kenya, was that really what is driving this is that during this lockdown period, when people can't access diagnostic and treatment services for TB, the number of TB cases that are undetected contributing to ongoing TB transmission increases. And what the modeling shows is that where there is modest lockdown, as shown by the orange bar on the right-hand graph, is what we would expect to see in terms of the monthly rates per 100,000. However, if commensurate with this, we put in place measures to mitigate the impact of this lockdown, such as strengthening access to quality-assured TB diagnostic, treatment, and preventive therapy services, intensifying infection control measures, scaling up active case finding and contact investigations, and introducing measures to deal with stigma both for TB, COVID-19, and HIV, as shown by the green dotted line in the right-hand graph. We can largely mitigate the effect of the lockdown on TB rates and death. However, of all the TB services, typically preventive therapy services have largely been neglected. And so we're only starting to see in South Africa and globally scaling up of TB preventive therapy. So I've already told you that the number of TB tests done has been halved, number of people starting treatment has been substantially reduced. What is happening to preventive therapy and what can we do to strengthen it? So now looking at the IPT uptake in South Africa during COVID-19, looking at some of the PEPFAR districts that we support through our partnership with CDC. In the first sub-district, we note that as the number of people newly starting on antiretroviral therapy has declined during the lockdown period, and so too has the number of people starting TB preventive therapy. But the target is to start at least 80% of people newly starting antiretroviral therapy on TPT. And although we saw a decline as we went into lockdown, the number of people who do actually start antiretroviral therapy has continued to increase. And in a second one of our sub-districts, we see a very similar picture. ARV initiation rates declining, similarly TPT rates declining, but as a proportion of people starting ARV, that has gone way up. So we've done well in some senses and not so well in other settings. However, our TPT programs continue to be rolled out, unlike what we've seen in other sub-Saharan African countries. So 3HP, which is a short course TB preventive therapy regimen of isoniazid and rifapentine, is a potential game changer. It is shorter, less toxic, associated with better adherence, and it has a higher barrier to resistance and at least similar efficacy to 6 months of isoniazid, and is less of a burden to both patients and programs. So what are we doing in South Africa in terms of planning to scale up 3HP? And so we've been hard at work in developing these plans, and just to acknowledge the leadership of Dr. Lindy Mvusi from the Department of Health, who's really led this whole initiative. So we've developed the stationery, we've been developing the training materials and conducting trainings. 3HP will be available in select clinics from July. And over the course of this year, we will be scaling up 3HP in 4 Global Fund supported districts in 4 provinces. with the aim of starting about 1 million people with HIV on 3HP. And next year, this will be further scaled up to include 23 districts supported by Global Fund PEPFAR and the Putuna supported districts. So in conclusion, the COVID-19 response potentially worsens TB control. COVID-19 may increase the risk of developing TB and worsen TB treatment and long-term outcomes, given that they both cause substantial lung damage. Strategies to help mitigate the impact of COVID-19 on TB control include integrating COVID-19 and TB services, and this includes scaling up 3HP, but we also need to address the impact of COVID-19 on HIV services, particularly starting patients on antiretroviral therapy, which is strongly linked to starting them on TB preventive therapy. 3HP for TB prevention among people living with HIV in context is a potential game changer, and South Africa is poised to start rolling out 3HP. Thank you.
Thank you very much, Gavin, for pointing out the important role that preventive TB treatment such as 3HP will play during the COVID outbreak as well. We have one more participant who is going to make some remarks, and that's Phumeza. Phumeza, we have now heard about all the problems that COVID-19 is causing for TB and HIV services, but does the COVID-19 screening process not also present us with opportunities to co-screen for HIV and TB?
So, yes, so in a recent article which was published by Bhekisisa, they refer to community healthcare workers as heroes on the ground during this pandemic of COVID-19, which is they're determined to do their job regardless of the reality they face on a daily basis. So we must do more to support them. A community healthcare worker is known as Nompilo in most townships. Well, this is a member of a community who has been selected in trust by his or her community to enter their homes and assist them to improve their health status. These people are the backbone of the healthcare system when it comes to TB and HIV. Yet they face many challenges. They often risk their own health by going on people's homes without the required protections, such as masks when it comes to TB. So this has led to them contracting TB and in some cases dying from it. For the last few years, TB Proof has been undertaking a community healthcare worker advocacy project to empower them as TB champions. Two of the major focus areas for TB Proof work has been to advocate for the release of a 4-year-old draft South African occupational health policy to protect health workers from TB, HIV in the workplace, as well as the implementation of the ward-based primary care outreach policy. So, in response to COVID-19, we conducted focus groups and workshops with community health workers in Hammanskraal, and they identified a need for quality training on COVID-19 and adequate provision of PPE as their top priorities to help them fill their roles in finding people with TB and COVID-19 safely. That training was supposed to be addressed through the implementation of the ward-based primary care outreach policy released 2 years ago, but no implementation plan has been released. As one of the community health workers from TB Group explains that they are not protected on their roles. Well, she said that it is painful to see our community health workers working without protective gear in these hard times of coronavirus. Her concern is how they are going to be protected from coronavirus. They do not have sanitizers or protective clothes, and they still do home visits. When our healthcare workers are sick, who will take good care of us? Because they will also be in need of care. These are ongoing concerns that are very, very worrying. So, TB Group has responded to COVID-19 like in several ways. Firstly, we developed a TB activist guide to coronavirus to help provide essential knowledge for community healthcare workers. Secondly, we were partners in the Mask for All campaign, which contributed to the guidelines recommending widespread use of masks in community settings by the South African government and eventually now also by the WHO. Thirdly, TB Proof recently submitted 2 advocacy letters in partnership with other civil society organizations, to the Minister of Health and the President. We are calling for the release and implementation of the policy on occupational health regarding TB and HIV, adequate training on TB and COVID-19, and provision of personal protective equipment. We also highlighted the central role of community healthcare workers in implementing the ward-based primary care outreach policy yet again. Well, in one of the letters, we emphasized that community healthcare workers need to be empowered so that they can teach their communities about prevention measures, including the safe and correct use of cloth masks, in addition to physical distancing, which is challenging in townships and other community settings. This is important because they represent like a trusted source of health information in our communities. People do not know why they should wear masks. They often complain that this is too hot and they can't breathe. They only wear it when they enter a store, but once inside, they pull it down. I think people's language could assist in this matter, like telling people that they should use them, like condoms are used as a prevention measure in the spread of HIV. It's the same thing if you think about it, just that it is different in how the protective barriers are used. For HIV, condoms, and for COVID-19, we use masks. So community healthcare workers can help to promote key public messages such as wear your mask to protect, we are wearing mine to protect you. As the number of people affected by COVID-19 in countries like South Africa increases, they play an essential role in supporting all aspects of the test, treat, and isolate approach, and provide much needed support while doing so. Community healthcare workers need our support since they are part of the affected communities and face higher risk due to their work. This includes provision of PPE and essential training.
Phumeza, I'm going to interrupt you here because we're a little bit past 5 minutes now. Thank you very much for pointing out the risk of community health workers and also the importance that they have protective equipment. I'm going to move on to questions now. Quite a few have come through, and I'm also going to ask some of the questions that have come through previously. So the first question is for Mary Ann, and that question is if you could expand a little bit more on the HIV patients who were more vulnerable to death risk. What was the difference between those on ARVs and those not on ARVs, and what kind of role did viral suppression play?
Sure. So, I think what we shared is that we're not seeing an effect of, we don't see a difference in that increased risk for people who are suppressed and people without viral suppression. But I want to highlight that in our COVID cases, about 2/3 of COVID cases, irrespective of whether they died or not, were virally suppressed. And so we've got a relatively small number of cases to date who have HIV and are not suppressed. And so clearly this is preliminary work, and we can't be as sure around that group who are not suppressed. What we haven't seen in our services, and our clinicians can bear me out here, is that we haven't seen huge numbers of patients on our services needing hospital admission who have advanced HIV and severe COVID. And we know that in our province, we have several people who do have advanced HIV. So we don't seem to be seeing a big effect of immune dysfunction, although clearly there's a lot of unpacking work that needs to be done here. The other thing I would like to highlight is that in the people with HIV who died, almost all of them had other comorbidities in addition to their HIV. So over half of them were also diabetic, nearly half were hypertensive, and several of them, a large proportion, about 40%, had previous or current tuberculosis. And then importantly, the risk factor that we don't have a good measurement on is obesity. And our clinicians tell us that they certainly are seeing that being overweight is a very important risk factor for poor COVID outcomes. And I think there's emerging evidence as well about lack of exercise and poor COVID outcomes. So the people that we're seeing who are dying with COVID and HIV are not people who have advanced HIV. They're actually people who've lived long enough to do relatively well on their HIV treatment and actually to develop these comorbidities. And we see a high comorbidity burden amongst our HIV and COVID deaths.
There's one follow-up question for you from someone who wants to know if the comorbidity is diabetes, is there a difference in risk between diabetes 1 and diabetes 2?
So I think because we're looking at adult patients here, and most diabetes in adult patients is type 2 diabetes, I think we really can't comment on type 1 diabetes. These are largely type 2 diabetics. Some of them may be insulin dependent because their diabetes may be severe enough to require treatment with insulin, but I think we can't comment on type 1 diabetics. There may be data from other settings.
Thank you very much, Mary-Ann. Francois, there's a question for you about whether we have any hard figures available of the impact on HIV services. And there's a second one that also asks, what is the plan for patients who have defaulted on their HIV and TB treatment? How are we going to catch up and address that?
So I haven't got hard data in terms of pickups. This DOH will have that data and should be able to help us with that. I have anecdotal reports from the sites, from people working there, the pharmacists, saying there is definite downturn. It's quite difficult because I think one of the interesting things about coronavirus is that we've managed to fast track a whole lot of policy decisions really quickly through, such as multi-medicine pickups and things like that, which we've been fighting for years. We also, at clinic levels, starting to triage patients with respiratory symptoms, which the TB program has been advocating for decades, try and separate people into all of this. So we're hoping that some of the benefits of this will be that we'll have a more rational dispensing program and a way to actually bring treatments more firmly to people with HIV. The question around how we're going to mop up, honestly, I think it's just going to be restarting therapy. If you're healthy and HIV positive, you can interrupt your therapy depending on your CD4 count for a couple of months. It's not great because there's a small chance of resistance. There is ongoing immune damage and you can transmit the virus, but you can go back onto your treatment. And almost every single person will suppress with the modern regimens at the moment. So I'm just more worried that we need to get back to normal in the sense of people being able to access primary healthcare clinics and things so that they can get back into the rhythm of getting their medicines and getting back and settled into their adherence settings again.
Very much. Gavin, there are two questions for you. The one is, would the fact that we need to wear masks now and social distance and wash our hands, would that also help to slow down the spread of TB? And then someone wants to know, when will be the TPT, the TB preventive treatment guidelines, be released in South Africa that we've been waiting for a while?
Thank you very much. So the COVID-19 responses has both a beneficial and a harmful effect on TB control. From the beneficial effect, clearly social distancing, that isolation, etc., helps interrupt transmission. But what it also does is it locks people with TB that either they've interrupted treatment, or if they have TB but it's undiagnosed, then battle to access diagnostic and treatment services. So there's a balance of both some benefit, but all the modeling that's been done to date suggests that ultimately the overall effect is harmful, which is why we are anticipating a rise in the number of TB cases and TB deaths. With respect to the TB preventive therapy guidelines, they have been going through various iterations, and they basically are ready for distribution. So they will be released fairly shortly by the Department of Health.
There is one other question for you here, Gavin, and that is, are we doing TB contact tracing efficiently while COVID-19 is happening? Are we continuing to trace TB patients?
So contact investigations have also dropped, as we've seen with TB tests, people started on treatment, specifically for TB. But what we have done is been scaling up contact investigations, doing households, going to households and evaluating contacts of COVID-19 cases. And what we need to do, and have failed to do so far, is really integrate the services to capitalize on the opportunities that COVID-19 presents to us. And TB has always been a fairly under-resourced service, where COVID-19 is being well-resourced. And so we need to tag onto COVID-19 and really make sure that we maximize the potential TB benefits by, as we're going into households, because people with COVID-19 type symptoms, which overlap with TB symptoms, also need to be screened for TB. So we should be doing both concomitantly. We should be using the opportunity to initiate people on treatment if they are diagnosed, and to start people with HIV and household contacts with TB on preventive therapy. So, there's lots of opportunities here to integrate and really for COVID-19 responses to draw on the lessons learned from TB and MDR TB, but similarly for TB to leverage what COVID-19 provides to us.
Thank you very much, Gavin. Moving on to Phumeza. Phumeza, there's a question. What can community health workers do to take charge of their own personal safety during the course of their work?
So obviously they cannot do this alone. They need
Phumeza, can you move a little bit closer to your computer? Your sound is a little bit muffled.
Sorry, I did not hear you.
This is a lot better, yes.
Can you hear me now?
Yes.
You're cutting off, Mia.
Yes, I can hear you now. Here, you sound a lot
Okay.
better now that you're closer.
So I was just saying that community healthcare workers cannot do this alone. They need help from civil society, help from the government, so that they can be able to go out and do their job without them having to worry that they might contract this COVID-19. So they need everyone's help to actually able to do their work perfectly.
So what is the methods that community health workers can use to lobby government to provide sufficient care?
Well, if they are not safe, nobody is. That's just it. Everyone should be able to do something. So if community healthcare workers are not safe, nobody is safe.
Okay. Phumeza's sound is cutting out a little bit, so I'm going to move on to another question. Francois, there is a question about, are there any lessons that we can learn from HIV and TB in order to deal with COVID-19?
Look, I think some of the stuff is unprecedented. I don't think we've ever seen something quite like this. I think there are lots of lessons we can draw from the HIV program around community response, community engagement. I think where I've been quite vocally critical of government, for instance, is not getting a social contract going. I think that when you explain the science behind things like social distancing, masks, etc., people buy into that stuff. And I think rather than the kind of krachtdadigheid, iron fist thing with the police and the army, we should have spent more time on explaining to people, like we did with HIV, how the virus gets into the cell, why adherence is so important. People participate and react to that much better. And I think HIV has taught us that, it's taught the whole medical field that buying from somebody is really, really important, which is a bit of a dire moment, I think, for the rest of the world. But I think the other thing HIV taught us is what you don't start with is threatening to lock people up. You drive people away from services, from testing services. We've seen in Soweto, for instance, reports as many as 30% of people refusing to participate in sampling in the COVID program because they're scared they're going to get locked up. And if you'd asked anyone in the TB or HIV world, they would have told you immediately that's a really dumb thing to start with. You'd rather get people to understand what they need to do. We've got extensive experience in this world, in this country, with MDR TB, with good community-based programs, where rather than locking everyone up, you go to the home and you explain what it's about, why ventilation is important. So those kind of things, I think there was plenty of experience here. We should have tapped into more in terms of both the HIV and the TB program.
Thank you, Francois. Mary Ann, there are two questions for you. The one is that question that we all want answers to, and that is, why do we see such high rates of COVID-19 in the Western Cape? I think everyone has been struggling to get an answer to that. This particular person says because also it's the case with TB, and yet there are very relatively low infection rates with HIV in the Western Cape, and there are not many mines. So why is that the case with TB and COVID? And then the second question is a bit of a government question. I'm not sure if you're the right person to answer it, but I'm going to try. Some TB facilities have been converted into COVID-19 hospitals. Are these decisions informed by policies, and how has it affected the TB patients in those facilities?
Thanks. I'll start with the first question. And in many ways, I wish I knew the answer to that question, because it's not easy to be the epicenter of the outbreak. I think the most likely hypothesis is that we had earlier seeding or earlier spread of COVID from international settings to the Western Cape. We know that the Western Cape is a very popular tourist destination, and there were probably a lot of tourists that came here and spread COVID without actually being diagnosed here. So I think well before we saw our first imported cases in returning travelers, we probably had tourists who were spreading COVID locally. I don't have good data to support that hypothesis, but I think that is the most likely. And certainly we did see early on, some of our early local cases were in people who work at tourist destinations. And we also quite early on, and I think before some of the other provinces, had people with COVID who had no international travel and no clear contact with a known case, which would suggest that community transmission or spread had started early in the province. I think there's a lot that we still need to understand in terms of risks of transmission, and we do know that other respiratory diseases, particularly tuberculosis, do seem to spread more readily in the Western Cape, and so that's a good hypothesis, but it's something that we would need to explore in more detail. And what we are hoping to do in the Western Cape is to start to do some genetic testing of the actual differences in the virus that we've seen, to really try to understand whether this hypothesis about earlier arrival in the Western Cape is likely to be true. In terms of the second question, I think as the province, we're very aware of the importance of maintaining our TB services, and we are very concerned and already looking very closely at the drop-offs that we have seen in TB testing. A lot of that is driven by people not coming for services. And in fact, if we look at the people who have come for services, the rate of TB screening is actually higher than before. And we are trying very much to integrate our COVID screening with TB screening. So encouraging people not just to be screened for COVID, but actually asking about TB symptoms as well. I think in terms of repurposing of facilities, obviously we do need to increase capacity for COVID. And so there has been some repurposing of facilities, but I think the province is certainly very concerned not to take our eye off TB, which we know is a huge burden in our setting.
Thank you very much. One other question here on the chat room is, what about smokers? Did you also look at that? I know you mentioned at the beginning in your presentation there were some complexities with looking at data for that. Do you just want to briefly comment on that again?
Yeah, so unfortunately this is routine population level data, and as I've said, it's based on either laboratory tests or medication that people have received. And because smoking doesn't involve either of those things, we don't have good data on smoking across the level of across our population. In our COVID cases, this is something we may be interested in looking at, and we did certainly in probably about our first 10,000 cases specifically collect information on that. So this is something that we hope to be able to look at, but at the moment, unfortunately, I can't comment on that.
Thank you for explaining that, Mary Ann. Gavin, there's a research question for you. Has the increased funding for COVID-19 research meant less is available for research into HIV and TB?
Thanks. So we have seen COVID-19 impact on research, but that's large in terms of the conduct of research. So trials that were currently enrolling, these are HIV and TB trials. We were instructed by our ethics committees and the funders, etc., to stop enrolling.
Gavin has frozen. We're just waiting for him to unfreeze. I think while Gavin is sorting out technical issues on his side, we can ask Francois a question so long. Francois, there is a treatment question for you that someone is asking, will you adapt or change the ARV treatment of someone with HIV if they have COVID? And also, would the antiretrovirals used by people with HIV be able to help to treat them if they contract the new coronavirus?
So there's no real change. There's nothing specific you need to do. Just keep your patient. Whoever's taking ARVs needs to remain on their ARVs. There's no drug interactions with the commonly used things we use to treat the symptoms of coronavirus. We don't have anything specific. There's one drug that is looking very promising, but we need to see those final results. We'll have a whole range of drugs available to us in the next few months, probably that are being evaluated for the treatment of COVID. But the short answer is just stay on your drugs. There was some cell culture data from one of our colleagues in Liverpool demonstrating that there might be some anti-coronavirus activity of tenofovir, which is almost every single South African with HIV is on. Unfortunately, the observational data we have so far hasn't borne out that it has any impact. In fact, the study from the UK seems to point to the fact that that is definitely not the case. We was kind of hoping that at least the HIV populations would have a form of almost pre-exposure prophylaxis with tenofovir, but unfortunately that doesn't seem to be the case. So the short answer is stay on your treatment, nothing changes.
Thank you. There's also a question about technology. They want to know, is there any role technology can play in helping to mitigate COVID effects and problems in countries where HIV is already highly problematic?
So we're the first big test case of a large population of HIV positive people. All the countries where COVID has struck hard, there have been a few cities like New York and Barcelona where there's a significant HIV population, but even that is nothing compared to what we have in South Africa in terms of just the sheer numbers of 7 million odd people with HIV. So yeah, I think that it's just going to be wait and see at this stage. And this is why I keep saying this, the data from Marianne and other people is absolutely critical for us how to plan our path going forward. The question about technology, they have used cell phone apps and even drones in certain countries to monitor the epidemic. I honestly think there's much more basic things we can do in which we're failing at, improving the hand washing, the social distancing education, looking at public transport and how people are queuing and the grants queues and things. These things are things we can impact on immediately without these high-tech complex things in place while we try and work out how to protect communities as best we can.
Thank you very much. Gavin, I wanted to see if you are back and if your sound is better again. It looks like we have lost Gavin, so we'll move on to Phumeza. Phumeza, how can we ensure that the solutions we come up are Africa specific?
Can you please repeat the question?
Yes. How can we ensure that the solutions we come up for COVID, specifically in terms of advocacy as well, are Africa specific and appropriate for Africa?
Okay, so I think some of you may know me from the point that I shared my story. So I just hope that the government will provide platforms for community healthcare workers and local COVID-19 survivors to share their stories, to break down the stigma and help spread essential public health messages. For instance, stories are powerful as they help to break down the stigma, and our healthcare workers are some of the best storytellers. Like, they are some of the most caring and dedicated healthcare workers. They and all the people they care for are the hope we must fight back against this deadly infection. And only by working together we can defeat this terrible COVID-19. So I think gathering of COVID-19 stories actually help raise awareness that it is there. There are people who come out alive from it, like I did, for instance, TB.
Phumeza, you also deal, thank you very much for that, and you also deal regularly with community health workers. What are some of the stories that you've heard about fears on the ground when it comes to COVID-19, and also experiences of community health workers that were previously used to track TB patients that have now been reappropriated reused to track patients for COVID-19?
So you say like the fears, like the some moments.
Yeah, no, the community health workers, what are the stories that you hear about fears from them at the moment with COVID-19?
So now, because it's really hard for us to have in-person talk, but then now they always complain that it's hard for them to go out there to assist people. So for now, we haven't gathered much stories when it comes to COVID-19. It's just that people are really, really anxious because they do not have the PPE so that they can be able to do their work. I hope I answered your question.
Okay, thank you, Phumeza. Mary Ann, there's a question that is a little bit of a government question again, from someone on YouTube who says we are losing healthcare workers to COVID-19 and often there's a lack of protective equipment. What is the government doing about it? And I know that you can only speak for the Western Cape government.
Yeah, I certainly can't speak for other provinces and even for the Western Cape. That's not specifically my responsibility, but I can say that in the public sector, we're very concerned about our healthcare workers. We're concerned about the number of infections in healthcare workers and obviously very saddened by the healthcare workers that have passed on from COVID. I think we are endeavoring to do whatever we can to ensure that people have the protective equipment that they need. And I think increasingly in our facilities, particularly with the challenges of testing, the important thing is to not lose one's guard at any point in terms of the risk of COVID transmission. So we tend to be very concerned when we're in the COVID ward, but sometimes we don't worry as much when we go to the tea room. And one of the things that we're realizing is that when we have a widespread epidemic, we actually need to put those protective measures in place everywhere we go. The simple things that Francois was talking about, the hand washing, the social distancing, and that's important, and that COVID spreads not just from patients to healthcare workers, but also between healthcare workers, and that healthcare workers can acquire COVID in a range of settings and not just in the hospitals. But we are absolutely concerned to provide as much protection as we can to our healthcare workers. And as I mentioned, we are just enormously appreciative of those who are working at the front line of our response.
Thank you, Mary Ann. Someone has also asked about death rates in the Western Cape, whether we are seeing any higher death rates. I have had a look at the figures and I saw that it's higher per 100,000 of the population, obviously because the infections are so common in the Western Cape, but that the general case fatality rate is not really higher. Is that more or less correct? And do you want to explain to us, what is happening with deaths in the Western Cape?
Yeah, so obviously we have more deaths than in the rest of the country and more deaths per 100,000 because we're at a more advanced stage of the epidemic. But in comparison to international settings, the case fatality rate or the proportion of people who die who are cases is pretty much what we expect. And particularly if we look by age and comorbidity status, it doesn't seem to be higher than what we're seeing from international settings. So we are relatively reassured that we're not seeing worse COVID outcomes than we've seen from around the world.
Thank you. Francois, there's a basic question for you from someone who wants to know, what is the difference? What is the difference in how you contract the new coronavirus and TB, or is it exactly the same?
So coronavirus, definitely, they both enter through the lungs. They seem to enter in the lower ends of the lungs, but the mechanisms are really only being played out. The coronavirus seems to have a fairly novel entry through the cellular wall, which may give us some hints as to why it's causing such havoc with the hypertensives and diabetics. And I see Emily's posted some stuff there as well about how the lymphocyte trafficking is different. So there are key differences. I think what people also often wonder about TB, there is overlap in the symptoms, but when you present with coronavirus, you tend to be fairly dramatic. It's a bit like having the flu. I'm fine today, tomorrow I'm not fine, and then the day after I'm really not fine. The TB tends to be a slow, even it's usually measured over weeks to months, or feeling a little bit off, then starting to cough and carrying on. So I think what's more difficult for us is differentiating in terms of presentation between flu and the common everyday colds that we have and the COVID symptoms, particularly younger people where they tend to have less severe symptoms.
Thank you. And there's a last question about testing for COVID, that you have been pretty vocal in strategies to use our testing better and more strategically. And how can we do those strategies, if you could explain, with COVID-19 so that there's more resources available in the process for HIV and TB as well?
So I think people need to understand, PCR test is a high-tech thing. It's not something you sort of like go to the factory and start manufacturing. And with PPE, we were able to go to manufacturers and start getting our stuff up and running within a week or two. We're kind of competing with the entire world for these resources. So we need to use them in a way that you get the maximum benefit from. And the people who desperately need their diagnosis are people being quarantined in the hospitals who are ill, but we don't know whether they've got COVID or not, so that we can separate the COVID positive people from the COVID negative people. We also need to prioritize the healthcare workers who might have just the everyday colds and sniffles and flu that you get over winter. What you don't want is a healthcare worker to be working in ICU if they've got COVID and looking after people who were hurt in accidents or who don't have COVID. So I've been and lots of my colleagues, are a little bit startled at how priority has been seen to be given to everyone in terms of testing, when we have to prioritize the hospitals first and then move to symptomatic other areas such as old age homes, clinics where people are ill are presenting. You have to have a triage system for this. What doesn't make sense is to test healthy people with absolutely no symptoms so they can go back to work, or sports stars who are probably so low risk of being sick anyway.
So I have a question that if we use PCR tests, which is similar to what we use for viral load testing for HIV, if we are using all these labs to now test for COVID, where are we testing for HIV? And is our ability to test for HIV significantly reduced in the process?
So I'm going to have to paraphrase my laboratory friends, but South Africa is one of the biggest PCR capabilities in the world because of the HIV viral load capacity, and we've got some of the best experts in the world in terms of scale up who are at the NHLS and in some of the other labs who are able to plan. They turn around millions and millions of viral loads every year. So the requisite expertise was there. It was a bit slow in terms of it being supported. The biggest problem at the moment is having the sufficient reagents to actually run the tests. And so we even ran our swabs briefly. So that's where the problem lies. The expertise and the capacity, the machines are actually there.
Thank you very much. We have about 4 minutes left of this webinar, so I would like to ask Mary Ann if she would like to make a closing statement. And Phumeza, it looks like we don't yet have Gavin back, and then after that we will end. Mary Ann?
Yeah, so I think just to say an enormous thank you for giving us the opportunity to share what we've learned about HIV and tuberculosis and COVID death risk. And I think our sort of headline comment about it is that in many ways, it's very helpful to have a number to quantify what this increased risk is. We might have expected that this number would be much, much higher in people who are immune suppressed with HIV and people with respiratory disease like tuberculosis. And so we're actually quite reassured that this number is not enormous, but nonetheless, it is very important for us to remember that people with HIV and TB need to be included when we're thinking about risk groups and people who we need to be on the alert for in terms of worse COVID outcomes. And that's something certainly that we'll be taking forward in the province and I think nationally.
Thanks, Mary Ann. Phumeza, a last word from your side.
So I'd like to emphasize on the point that if healthcare workers are not safe, nobody is. Like we have seen the unacceptable risk of TB faced by healthcare workers, and we must now respond to the risk.
Phumeza, can you move a little bit closer to your computer because your sound is not clear?
Okay. So I was just saying I need to emphasize on the point that if healthcare workers are not safe, nobody is. We have seen the unacceptable risk of TB faced by healthcare workers and must now respond to the risk of COVID-19, which is another respiratory infection. So the TB community is well placed to contribute to respond to COVID-19 between these pandemics. As the Select Civil Society Forum Research noted, we cannot deal with any of these enemies in isolation.
Thank you very much, Phumeza. I would like to really thank Francois, Mary-Ann, Gavin, and Phumeza for being such great panelists in this webinar. Mary-Ann, thank you very much for releasing really meaningful and important data that is really useful to our country and also to us as the media to report on. Francois, thank you for sharing all your expertise and your experience in practice as a doctor and a researcher. Phumeza, thank you for your community experiences. And Gavin, who is not here right now, I'm very sorry that we lost you. If you are interested in a recording of this webinar, the recording will be available on Bhekisisa.org almost immediately after the webinar. It will be the YouTube link to the webinar, and we'll also be sending out an email with a link and some other resources to everyone who registered for this webinar. Thank you very much for joining us, and stay safe.